So we think about our NC Pre-K as the last best chance for our kids to get ready for kindergarten. It has amazing educational outcomes through, now I think they're saying high school. And then we also see that our pre-K funding is about half of what it is for public school. And so just as our earlier guest spoke about, you can't operate a business at 50% of the cost when you are going 50% in the hole every year. And so I think that's what's happening. I will say that we are in contact with your county and working with those providers individually. So if any of you have constituents concerned about that individually, we're working with people to make sure that we are helping find solutions and not just identifying problems. But this is a giant challenge that we face in NC Pre-K, is that it was always intended to have a local component where we know, I do not know the programs in your community that should be NC Pre-K programs. I don't ever want to have that responsibility. That is best done at the local level. But what I do know is that it just costs $11,000 to do NC Pre-K, and right now we're funding it at 48% of that. So to sum it up and to leave time for more questions, or not, depending on how fast we go. Sorry. We wanted to come in support of the QRIS modernization, in support of the commission and all that they've done to bring about this really transformative process for our state. It's one of those innovations that we're so excited about, and to ask for your support on some proposed legislation. We wanted to remind you that the stabilization grants are running out, that we are tipping over the edge of that cliff. To remind you about that subsidy rate floor. And when I talked, if you all will remember the programs that closed out west this fall, when I was talking to them and their board, I said, what would have happened if that subsidy rate floor had been in place? And they said that would have made our bottom line work. So that's a fix, especially for our rural communities, which I have great concerns about. And then to just share with you the dollar-to-dollar data on NC Pre-K and how hard it is for our private providers, which I love our school districts and we partner with them all the time, but they don't have space or room or even necessarily the function of doing pre-K for all of our children, our 4-year-olds across the state. We need our private providers in that, and our private providers are the ones set up for 0 to 5 care. That's their bread and butter. And then we've put into the appendix for you all to look at your leisure, the pipeline innovation. So we in the community college system and our partners across the state have done a huge amount of work in the last 2 years to make sure that people have every door wide open to get into early childhood. Really proud of that work. So thank you for letting me share some of the successes and excitement that we have, and also some of the challenges that we are up against right this second. Thank you, sir.
Thank you very much. You had a difficult task to do. Right now you're in Director Crosbie's time, and she's already texted me and said she didn't appreciate this very much, but I would never hear the end of it. Senator Jarvis and I have been friends 40 years. Representative Baker and I have been friends a little less than that. But I would never hear the end of it if I didn't recognize her. So, Representative Kristen Baker, you're recognized.
Thank you, Mr. Chair. And in the interest of time, I won't pursue the question. I'll follow up with you, but I just appreciate so much, Director Ford, your work and the work of the commission. And I particularly think that the credentialing expansion is going to be very effective. And I know I've worked with y'all on that, and thank you so much.
Thank you, Representative Baker. Senator Jarvis.
Thank you, Mr. Chairman. And thank you, Director Ford, for all the work that y'all have done. Did a great job. One question I had, whenever we look at the workforce pipeline and the issues that surround all that, I know we many times talk about the fact that experience, do we have a pathway of experience outside of, college degree or certifications? Is there a pathway that experience can be used in that pathway?
Director Ford.
Thank you for that question. I'm excited to answer. So yes, there is the short answer. There's multiple ways that shows up. So there was one that's called credit for prior learning, and that can lead into a college pathway if folks want to pursue that. But the commission also, and I'm not sharing any secrets because she shared this publicly at commission, but our vice chair, she uses her own family, and she says, my daughter is just, school is not her thing, and she is a brilliant infant teacher, so there is a pathway that works on what we call competencies. So experience in and of itself, we know if you're experienced in a place that's low quality, that's not good for kids, that's not what we want either. So we want to make sure there's still a way to verify that those teachers are doing all of the best practices, but but recognizing that education comes in a lot of different ways anymore. So thank you for the question. Yes.
Thank you, Director Ford, for all your hard work and department and your people you work with. We appreciate it. If Chair recognizes Kelly Crosbie, Director of Division of Mental Health, and if you're enthusiastic as your predecessor was, it'll be an interesting presentation. Thank you.
Thank you so much, Chairman Potts. Hello, everyone. Kelly Crosbie, and I'm the Director of our Division of Mental Health, Developmental Disabilities, and Substance Use Services. And I was going to say I am incredibly enthusiastic. For those of you that know me, I'm incredibly excited about giving this presentation today. I'm really passionate about the work and grateful to be able to speak to you today. The first thing I want to do is remind folks of the actual investment that we're talking about. Ooh, I got the right button. Okay. So as a reminder, and I have a Herculean task today, which is to try to explain to you our approach to spending these dollars, investing these dollars in North Carolinians, and to give you a highlight of some of the things we're investing in year one and year two. So as a reminder, first I'm going to say thank you. Thank you to the chair and the vice chair of this committee, to so many members of this committee, to Representative Lambeth for his championing this work. We're very grateful for these investments in behavioral health. And the first thing I want to say is that we are doing everything to spend these responsibly and to the greatest effect. As a reminder, we were funded in 5 major areas. The first was Medicaid reimbursement rates for behavioral health, crisis system investments, justice system investments. So these are people with mental health, substance use, intellectual and developmental disabilities, and traumatic brain injury who intersect in the justice system. Behavioral health workforce funding, and child behavioral health funding. So these were the 5 different categories of funding that we received. I just went backwards. I want to tell you just a bit about our approach. This is a lot of money. So with year one investments, we wanted to focus on funding current successful programs to spread and to really utilize some unused infrastructure in the system. So shovel ready is not quite the right word. We looked at facilities that were already available that needed upfitting, projects that were already near to completion, places that had room to expand. Maybe we could add some beds to a facility. So we were trying to think of really cost-effective, efficient infrastructure investments, things that we could start using right away. In year two, yes, we were doing the first year to do some sort of shovel-ready or immediately ready projects to expand existing successful programs. But in year two, we're thinking about improving the quality of existing programs. So you'll hear that a lot throughout. We do have a lot of programs that do need additional investments to improve staffing or models of care. And also we're always thinking about, but year two will have a specific focus on financial sustainability. A lot of the models we will leverage Medicaid, but we are giving careful thought to how we do that and how we make sure we leverage all available state and federal dollars to keep these investments going. Here was our approach. It was incredibly important that we engaged our community partners. So we kicked off this work in December. So after the budget was passed, we kicked off this work with our community. We have monthly webinars. They're called Side by Side. That's how we think about doing our work. We do our work in partnership with the community. So we kicked off our work, and every month we meet with the community to talk about these investments. We feature a key investment every month. We talk about the work that we've been doing in that space. So it's really important that we're transparent and we're engaging everyone. Typically about 400 people attend those every month. So there's a lot of interest and we're excited about that. We think it's important to be transparent. But for each funding stream, we've also launched advisory groups. So those started at the beginning of the year. So every month we have a specific advisory group for each of the funding. Those are incredibly well attended. We've got LMEs, of course, LMEs are at the table, counties, DAC, Department of Adult Corrections, Department of Juvenile Justice. We've got providers, we've got consumers and families. I think I mentioned counties. We've got folks from law enforcement, folks EMT, so emergency medical transport folks, because these are investments that involve everybody in the community. So we're going to be really transparent, but we also want their advice on what to do. So we're engaging the community. And also, you'll hear about some early investments. We're making sure that we're doing this fairly, right? So for our first crisis investments, we did a request for information. We have another request for information out right now to all of our child residential providers. So we're trying to make sure we're open, transparent, and fair. We're also using data wisely, right? We need to. So a really good example of that is our year one crisis investments. We're investing in infrastructure, and I'll explain what that means later, in places where we have high emergency department holds. We have no places for people to go besides the emergency room. So those, we're using data to be smart about where we put investments. And lastly, we're building in measures of success right from the beginning. So we have a host of things we're tracking right from the get-go, right? We want to make sure that we have the problem identified, we can quantify it, we can say this is the right investment based upon the data that we have and the success of current programs that look like this. And we will start measuring success from day one. And I'll actually show you a metric we're tracking that's already going down. So I'm going to do my best in this brief amount of time to look at each investment area. I want to tell you a little bit about the challenges of that area, our vision for that area, and also some planned investments in year one and year two. So that's a lot to cover. I'll do my best, but I also want to leave time for questions in case there's an area you want to dig deeper on. So the first is pretty easy, but so impactful. Those Medicaid reimbursement rates, they went into effect January 1st. In places where we had a Medicare comparable rate, we funded the rates to 100% and even some cases 120% of Medicare. Overall, we had about a 20% rate increase across all behavioral health rates. We hope the net effect of this is getting more people to come into the workforce, more licensed professionals, that providers will have an easier time of hiring and recruiting staff into the public system. So we'll be tracking that. Sorry, I'm stuck. Okay, crisis system. This is probably the one I will spend the most time on. This is a bit of a busy slide, but we got a really nice investment in our crisis system. Our behavioral health, so our mental health, our substance use crisis system doesn't work very well. I think all of you get calls, just like I do, every week about things that are not working in the crisis system. People are waiting too long for crisis response in their communities. They don't know who to call. We often use things like involuntary commitment. We use things like police transportation. People go immediately to the hospital. So we use very restrictive methods when people have mental health crises. The distribution of crisis services and facilities is incredibly uneven across counties. It's very different how crisis systems operate across the state. And overall, the crisis system is really, really underfunded. A lot of people use the behavioral health crisis system, but it's sort of solely funded by Medicaid and state dollars, even though folks with other insurance are using the crisis system. This is our vision. I would love you to leave with this vision today, this mantra. We are trying to build a system of crisis to care. And for us, that means someone to call, someone to respond, and a place to go. That makes a lot of sense, right? When you think about the 911 crisis response system, that's what it is. We have sort of the bones of this system in North Carolina. It's just fragmented and not consistent and certainly not well funded. It's certainly not well known. A lot of people don't even know how to access this system. When I ask people, do you know where the behavioral health urgent care is in your community? Most people have no idea. When I say, do you know where the crisis center is? Not the emergency room, but the psychiatric crisis center, nobody knows where that is, okay? So they do exist, but we need more of them, and they need to be well known, and they need to be trusted. So there's a lot of folks that don't necessarily trust this system, right? So someone to call means 988. Most people know 988 really well. We launched it in July of last year. We get over 7,500 callers a month. It's tremendous, and it's easy. People know how to call 988, Okay. We also launched our peer warm line, which is 1-855-PEERS-NC, so people can call and talk to another person in recovery who understands recovery and understands our treatment system and how to navigate it. LMEs also have their call centers, local management entities. So we have someone to call, and people are calling, which is incredibly exciting. Now they need someone to respond. 988 right now can deploy something called mobile crisis. That's mental health crisis specific response teams. It's an unmarked car. It's not law enforcement. It's not EMT. It's a trained mental health professional who can go to someone's home quietly. And the goal is to de-escalate the situation, provide supports to the individual and their family, and help them get connected to care the next day. That's the goal. That's it. We don't have that consistently across the state. Response times can be up to 5 hours. People don't always know the mobile crisis team. They have 1-800 numbers. People don't know what it is. So we need more in these teams. We need them to be consistent. We need them to be deployed by 988. We need people to know them and to trust them. We also have something called Mobile Crisis MORS. This is important. Mobile Crisis MORS is a specific response team specifically for adolescents. So that's a really important team. We only have 7 of those across the state, so we need more. But the last thing we need is somewhere to go. Urgent cares. Everybody knows what urgent cares are. We have behavioral health urgent cares. You might not know that. But there's not enough of them. Some are open 12 hours, some are open 24 hours, some do detox, some don't, some are for kids, some are for adults. So they're inconsistent, they're not always open, and people typically don't know where they are. But they're just like any other urgent care, but they're specifically for mental health issues. We also have things called facility-based crisis. Again, people don't know what they are. They are freestanding little psychiatric facilities. They're small. They're like 8 to 12 beds. They're for adolescents or adults. Again, it's the right place for people to go rather than to have to go to the emergency room. But we have alternatives to that too. We have peer respite centers, not enough of them, but they are also alternative crisis spots for people to go to. And we have the wonderful NC START program, which is for people with intellectual and developmental disabilities. We have very few beds across the state there. So all of this, it's the right system. Someone to call, someone to respond, and a place to go. We don't have enough of it, and it's not well enough known. So, I'm not going to go through this slide, but this tells you the typical journey when someone calls 911 and the journey we want to create when someone calls 988 instead. I'll leave that with you. This is really important. These are some of the first investments you're going to see start coming out. These are places to go, by and large. These are behavioral health urgent cares and these freestanding facility-based crises. We are adding 44 new beds for kids, 64 new beds for adults, 9 new behavioral health urgent cares, and 1 new co-response team. So that's mobile crisis, that mental health and law enforcement going together to respond. The counties, the darker the county, it's the higher number of emergency department holds, people waiting in emergency departments. So again, remember, we're trying to be really smart. We know patterns of care. We know where people are waiting for care. And we're trying to build these urgent cares and facility-based crises so people can divert from emergency departments and go to these alternative sites instead. So these are the first round of investments that you're going to see coming out from the crisis system. All right, moving on to year 2 investments. So year 1, you can see, is very much somewhere to go. In year 2, we're going to focus on a lot of things, but the 2 I want to point out to you are more of those mobile crisis teams. We need response in under 30 minutes. We need well-staffed teams. And we also need alternative transportation. So we'll be funding some non-law enforcement transportation pilots. We don't need people going in the back of police cars to psychiatric facilities, right? In handcuffs. It's not the best role. Our law enforcement partners are aligned with us on this. We want to make sure that we have alternative, safe transportation for people in psychiatric crisis. Okay, so moving on to justice investments. There's a lot of data on this slide, but there's one takeaway point. A lot of people who get involved in the justice system who are incarcerated have mental health or substance use issues. We have tons of data that will tell you that. Tons and tons and tons, okay? We just put some of the statistics here. So here's our vision for the continuum of mental health and substance use care for individuals involved in the justice system. First, we want something called diversion and deflection, and that means we want to make sure that whoever responds to a crisis has mental health training, that we can divert people into treatment rather than having them go to jail or go to court, or if they go to court, to get treatment instead of being incarcerated. So we want diversion and deflection. We also want to make sure that when people are in prison and jail that we have adequate treatment. That's mental health and substance use treatment. And we have more capacity restoration. I think you've heard of that before. Capacity restoration is really important. That means people who are incarcerated who need mental health treatment in order to go to trial so they can go home. This is not having enough capacity restoration is really jamming up our state facility beds, and it is keeping people with mental health issues in prison way longer than they need to be, and it's actually leading to some backups in our emergency rooms. So we need more treatment while people are incarcerated. And we also need more reentry services. That means we're making sure that we help people transition back into the community, but that we also in all communities have the right set of services, mental health and substance use services, for people who are involved in the justice system. It's a specialized skill set. And what I have on here are just some examples of programs we have that need to be expanded. One of our year one investments, just to celebrate one success, is our UNC Fit Wellness Clinic. It's here in the Triangle. They have incredible success rates. They provide care management, but also medical care and mental health care to folks coming out of prison. And these folks they have very complex needs. They've been incarcerated for a long time, and or maybe multiple times, but these wraparound services are proving incredibly successful. Folks are getting good medical care. They're avoiding higher cost urgent and emergent care, both mental health and physical health care, but they're also getting connected to needed resources in their community. That's everything from treatment to housing to employment. So folks are re-entering the community successfully. So this is just one example of a re-entry program that we are going to expand with some of these dollars. On this map, do you see the little map? These are counties where we have these re-entry programs across the state right now. So what we're doing right now is we're looking at all those to see where can we expand, but look at all the counties that don't have things. What other counties? We're being smart with data, we're being smart in talking to the community. What other counties do we need these re-entry programs in? Re-entry programs, but also specific mental health and substance use services. So that's how we're also thinking of year one investments. Year two, we want to do more of those diversion programs. So we want to make sure that we're doing a good job of training court officers about alternatives. We're making sure that we have alternative treatments and diversion programs in communities. And that map again shows you where we have these diversion and deflection programs currently. So we're looking at ones we can expand and also counties without. So places we can begin additional deflection programs. I'm going to turn to workforce now. This slide, again, has a lot of statistics about the struggles that we have with behavioral health workforce. Probably some of the most startling are, the vast majority of our counties do not have a psychiatrist, vast majority do not have a psychologist. This is the highest level specialized mental health treatment, but you need those folks for very specific things. But we don't have just enough licensed social workers like I am. People like me provide the bulk of mental health counseling and treatment to individuals and family. There's not enough of me. Licensed people are not going into the public field. Rate increases will help, but we still need other ways to entice social workers, licensed social workers, and substance use counselors to come into the field. We also have a lot of unlicensed mental health professionals. So we need to recruit them, but we also need to make sure they're well trained. I've mentioned I was actually at the Medicaid JLOC, I think it was 2 weeks ago, and talked about direct support professionals. We're going to need at least 20,000 more direct support professionals to make sure that people with intellectual and developmental disabilities can get services in their community. And we have an untapped resource. We have something called peer support specialists, and I'll tell you why they're special in a moment. But these are people with lived experience. They are being certified, but they're not necessarily getting and maintaining employment in our system, and that's a real loss. That's something that we need to capitalize on. So what is our vision? The first thing I'm going to say is that we want a recovery-centered behavioral health system. Why do I even mention that, right? That sounds pretty jargony, but it actually means that we want clinicians and we want the kind of workforce that is not about helping people manage their symptoms. It's about helping people be well, and live life and get a house and be a productive member of their community, take care of their family and get a job. So we want a recovery-oriented system, not a sickness-oriented symptom where we're trying to manage hospitalizations and medications, right? And that means we need a well-trained workforce. So we need a lot of licensed people coming into the field. They need better compensation. The Medicaid rates help. But for a lot of those unlicensed folks, they need better training, and we need to make sure they're well trained in recovery-oriented methods. And we need to use those folks, peer support specialists who've been there, done that, know the system, really helping other people on their recovery journey. So people need training, they need incentives to actually come into the public workforce, but we also need to help employers. I work with tons of providers. They're the best. They are really struggling to recruit and maintain workforce because just like Director Ford shared, we're competing with other people for that same workforce. We're competing with Target and Verizon, and these are not easy jobs, but they're terribly meaningful. So we need good rates, and we need to give employers tools to keep people employed. So investments, a couple of investments that I would highlight is we are working on a wonderful program with Wake Community College to train direct support professionals, make it a real career path. So we're getting to kids in high school, we're getting to people in college. It's a real career path with career advancement tied to rate increases. We're also working on an improved and easier peer certification program, but also peer to employer matching programs so we get people employed. We are working on investments that you gave us to make sure that we are offering things like loan forgiveness and other incentives to have licensed people come into the field. And of course, again, thank you for those behavioral health rate increases. We think they'll make a big difference. The last thing I'll talk about are the investments in child and family well-being, or sometimes I just call this child behavioral health, but I believe Director Ford said it. Children are in families and in communities. This is some really important data. We track a lot of data in the child behavioral health system, but these two key points, remember I said we all get phone calls? We get phone calls about these two things all the time, all of us do, right? We've got children in emergency departments. Each week, about 54 children are waiting in emergency departments. They're waiting for a better residential placement, a therapeutic placement that can meet their needs. And we used to have 32 children in DSS custody in DSS offices or hotels. But look, that number's going down. It's still too high, don't get me wrong, but the average now is actually 19 children. So this is an example of things we're measuring up front and an early success, and I'll show you why. Here's our vision for the behavioral health system. There's a lot of words on here, but it's simple. I mean, we're just humans, right? We want our kids to be at home. We don't want them to be in crisis. If they need treatment, we want it to be effective, therapeutic. We want it to involve the child and the entire family. We want kids in non-emergency rooms or out-of-state psychiatric placements. We want them in communities. So these are just common everyday goals, but there's a lot of fancy words that say that. Here's a year one investment that we think is really helping to drive down that number of children in DSS offices. And Deputy Secretary Susan Osborne is here as well, if anyone has any questions about these investments. But about $8 million went to local DSS offices for them to develop alternative settings for children who might end up in emergency rooms or DSS offices. And they've been able to implement this new funding to offer alternative family placements, to have families waiting and on hold if they had these urgent situations where they needed to place children with more complex needs, and it's already making a difference. Some other investments that we're planning, I'll just tell you about two. One is professional foster parenting, and this is a really good example of making sure that we have an evidence-based therapeutic environment where a child is in a home receiving therapeutic intervention by foster parents. And we already have evidence of this working really well, where children are being reunified with their family of origin after successfully being in this home-like therapeutic environment. These are other things we intend to do with that $80 million child investment. A lot of words, but the big takeaways are we are investing in more community-based programs for kids. So again, part of our issue is that we have some really good things we call wraparound services, and they are what they sound like. We're able to provide services to the child, to the family of origin, to the treatment foster care home. They're all getting therapy. They're getting coordination, supports with school. We have those. We just don't have them statewide. We need to make sure they're statewide and available to all and effective and well-staffed. So we're doing more of those. But we're also working on our residential treatment array. We want kids in community, right? We do. But we do have kids now in residential facilities. That's something we track. We track how long they've been there, where they are they in state, out of state, what are their diagnoses? Are they in DSS custody or not? How old are they? What was their treatment trajectory? And we know that we need kids staying less time in residential facilities. We need them in state. We need them closer to their communities. And we need enough special residential facilities that can meet the complex needs of our children. And these are children with intellectual disabilities and behavioral health needs. These are children who have been traumatized. These are children who sometimes have acting out aggressive behavior because of the trauma they've experienced. These are young children. Ideally, we don't want anyone in residential treatment, but if they are in residential treatment, we want them to have the best experience they can. I mentioned the RFIs out right now. We have one right now out to all residential providers to say, with some of our year one funds, you've got kids now. How can we help you provide a better, more therapeutic environment for those kids? Can we upstaff? Can we help you buy new furniture, decorate the rooms, make it more home-like, fix up your outdoor space so children have time for recreation out of doors? Can we train your staff on more trauma-informed treatment practices? So we have that out right now because we want it open to everybody. We want it to be a very transparent process. And we want to do some good now. Making longer-term changes to the residential system will take time. It's important, but we want to make some now changes. So that was the whirlwind tour of those 5 buckets of investments. Happy to answer any questions. And there's information in the appendix too, if anyone wants to know about our engagement approach or some more about some of the investments, that's in the appendix.
It was more like a hurricane tour, but you were well prepared. So we'll know the time that we have left, and I see Representative White was on. Why don't we, since you're going to do the 122C policy, why don't we do that, and then we'll have questions. You're recognized for that.
All right, thank you, sir. So 122C. All right, and this will be, hopefully this will be quick. But as the slides are coming up to talk about 122C, and this is Kelly Crosbie. I'm the director of the Division of Mental Health, Developmental Disabilities, and Substance Use Services. You all have heard Secretary Kinsley talk about 122C. He always says that 122C went into effect the year he was born. Okay? And I am older than 122C, so let me just say that. But I say that because I sacrifice my vanity, because the changes that we're talking about are actually really, really important. So, but what I want to do today is actually tell you more about the process of the 122C, the why and the process of how we're getting there. But just as a reminder to set the stage about 122C, they're quite old. They're really important to my division, and they're important to a lot of people sitting back there because they are the rules that govern our public mental health, substance use, intellectual and developmental disability, and traumatic brain injury system. They involve the local management entities. They involve our state facilities. They're a big deal, and they haven't been updated in 40 years. The world has changed a lot in 40 years. Now, they've been patchworked over time, but it's led to a bunch of fractured rules. They do not reflect our current system. They do need to be modernized. And they do have to reflect things like our transition to managed care. So there's a why. There's some really critical things. Let me tell you the why now, too. There are really certain things. We pulled up some really key areas in 122C that really need to be looked at. I mentioned this in my last presentation. Every day we have about 300 people waiting in emergency departments. Many of them, the vast majority, are actually adults, and they need a higher level of care. So they need a community psychiatric bed or a state psychiatric bed. A third of our state psychiatric beds are people that are waiting for capacity restoration. These are how all the puzzle pieces fit together. If the rules allowed us to have alternative capacity restoration sites like detention centers and community-based capacity restoration, we could free up those state beds, meaning we could get people out of the emergency room and into our state beds. So that is one example of a rule that's got to be modernized so we can fix some of our flow-through pattern of care. We also have things like outpatient commitment, where people can live in the community, but they have a commitment order that says, and you have to go to treatment. Those need to be modernized. Again, they haven't been modernized for decades. So outpatient commitment has changed. We want to make sure that when people do get an outpatient commitment, it accurately reflects the treatment they're supposed to get. Right now, they're often open-ended. So people who are on these outpatient commitments don't even know what they have to do to get off of them. So minor changes, but that will actually improve and make the process a bit more meaningful. Let's make sure the outpatient commitment says what the treatment order is, what the medications are, so people know how to get their treatment and fix it. Okay, so these are just a couple of examples, but these things need to be changed. These are critical things that need to be changed. let's talk about the process a little bit. This is very public. And one thing I want to stress is that I just gave you a little taste of a couple things that need to be changed, probably some of the most important things. But know that we don't have anything baked yet. I want to be clear. Like, I'm not here today to give you a list of baked things because we're still in the vital process of engaging with the community. So we've had over 23 meetings with stakeholders right now, and that's everybody. Hospital associations, the administrative officers of the courts. I've met myself, I meet a lot with our State Consumer and Family Advisory Council. They're really important to me, and their voice is really important in this process. I've met with them maybe 4 or 5 times about these things because we care. We want to make sure that these rules about the public mental health substance use IDD and TBI system make sense to everyone. Everyone has a chance to give input. We're reading through written input right now. We're talking about all the meetings that we're having. We're having ongoing meetings with stakeholders. And after those discussions, we're going to come with what we hope is a very succinct and reasonable package of proposed changes, but we're not there yet. So just want folks to know, because you've heard about it. We are in the process of engaging with stakeholders, but we don't have any final recommendations yet, but we're taking that stakeholder engagement process really seriously. So that was a quick one, Mr. Chair.
Thank you very much. It's good to know that you're older than 122C. We have people in here who are older than 122 years. I'm not going to say who they are, but one of them just perked up. A preacher once said, if you throw a rock in a pack of dogs, it's usually the one who got hit who yelps, so I won't say who that was. But I'd like to recognize Representative White, who's not older than 122 years.
Thank you, Mr. Chair. This is for Mrs. Crosbie. When we, it was in the second package, I think, page 22, DSS emergency placement funds. Could you speak just a little bit to the creative solutions that you're using to place? And also, I've just recently seen, like this week or the last couple of weeks, signs at the local post office on the roadway, not in the post office, but on the roadway, the driveways, about responding to DSS if you want to, take care of a foster child. Could you expounded just a little bit on about the safety and security measures that you're using since you're opening this up to the general public? And we know there are perverts and all kinds of folks riding around seeing these signs. And I'm sure this is this is reimbursable. It's not free care. So could you kind of just expound on that a little bit?
Director Crosbie, you're recognized.
Thank you, sir. And thank you, Representative White. Those are fantastic questions. But Chairman Potts, could I actually defer the question to Deputy Secretary Osborne?
You may, you're recognized.
Thank you, Representative White. We're excited about the emergency placement. We use best practice from counties and from another state to develop this program. We used almost $8 million of the funds that you gave us. And what we've allowed counties to do, we've allocated the money, the almost $8 million for this year and year 2, and counties have an allocation. And their allocation is for them to help create local solutions to preventing children from spending the night in a DSS and an emergency room if possible. And so the options are either using those funds with a current licensed foster parent, therapeutic, those folks who are screened, criminal background checks with the SBI, all those pieces. So it's not open to the public, but it is for currently licensed foster parents, therapeutic parents. It may be to hold a bed. So I'll give you an example. A therapeutic foster parent had a young child, a 12-year-old, who needed to go into a hospital. This is a foster child, needed to go into a hospital to be stabilized and receive some new medication. Normally, while that child is in the hospital, Medicaid will only pay for that hospitalization and we cannot hold the bed for that child in the therapeutic home. And so what the county was able to do with these emergency funds is to pay to hold that bed for that child. So when he was released from the hospital, he had a stable place to return to, could go back to the same school, could continue his outpatient treatment. So that's option one. The third option for counties is to create a solution and submit it. We just want to make sure these funds are being used to prevent kids from being in DSS offices and emergency rooms. So we're total of about 8 million in counties. I'll have later this week the first update on spending, but we are very excited, as Director Crosbie shared with you, our numbers of kids in DSS offices are going down. That's one intervention. There's many interventions that are making a difference here.
Thank you. Follow up.
But my question was, with the signs on the highway, it appears that, anyone can become a foster parent. And I'm just saying that are we making sure that we process? You're talking about things that's already in place and we're just trying to improve them with more money. I'm talking about new signs that's up that's saying, if you'd like to be a foster parent, we need your help on the side of the highway.
Yes, so we do have a statewide campaign. During COVID, as most states did, we lost a number of foster homes during that time. So we are recruiting statewide. Our LMEs are recruiting and our private agencies are recruiting. But there is a stringent process that includes SBI checks. It's a 10-week program. It is home visits, home studies, employment records, all of those things. But there is a recruitment campaign underway.
Senator Bergen.
Thank you, Mr. Chairman. Just a real quick statement and then a question, if that's permissible.
It is. The Senate's been very good today.
This is the first question on our side.
Senator Adcock must have texted each of you.
She did. Thank you, sir. We're always good. Thank you. The statement is, Deputy Secretary, I want to talk about Deputy Secretary Kerry Brown. There's a group that's working with Judge Newby right now, looking at this whole 122C, and so I'm glad, Director Crosbie, that you brought this up. But we're going to have to do some things to make that work and change some laws, and so I know that everybody is looking at it, but we need to move this as quickly as possible and to free up those beds. We've got, I think the estimate's 300 and something people right now that are in some of our most expensive beds being treated because the court says that, or our system now says that's where they have to go to be treated, that we could get them into a lower level of care, even do it in jails and other places other than these very expensive beds. So thank all of you that are working on that. My question is, when a child is in a facility, is there a requirement on how many hours or minutes of treatment they receive per week or per day? Because I have gotten all kinds of mixed responses to that question. If not, we need to establish something, because having a child in a facility, psychiatric residential treatment facility or any facility, without a requirement for treatment is pointless to me. Thank you, Mr. Chairman.
Director Crosbie.
Kelly Crosbie, Director of DMH DDSUS. Thank you, Senator Bergen, for your comments and your support of changes to 122C, and thank you for your question. So the question about, is there a minimum standard for treatment in some of these residential facilities? I will say there are some minimum standards, but they're just not enough. So there are very outdated rules for our residential facilities, including PRTF, Psychiatric Residential Treatment Facility, which is our highest level of treatment. There are staffing standards, right? There's an amount of therapy or a therapist or a psychiatrist that should be involved in the facility. But they're just not strong enough rules. So one of the things we're undertaking is to actually change the rules to make sure that we have higher standards for the amount of therapy that is happening inside the facilities. I will say it is person-centered as well, which is a little harder thing to quantify, meaning, some children might need individual, family, group therapy. They might need it more times in a week than other children, but there has to be at least a minimum standard. And there are some minimum standards, but again, with that really high level of care and with the goal of it being brief, also person-centered, but incredibly effective, those rules really need to be updated.
Senator Bergen, you're recognized.
Would 15 minutes a week, you think, be adequate?
No, sir.
I don't either. Thank you.
Representative Reeder.
Thank you very much. Question about the new crisis facilities. You listed the number that you're trying to do. Are those going to be public partner, state? How do you envision those? And then the second part of my one question is that the needs assessment about the intensive home treatment settings, those residential programs, has there been a comprehensive needs assessment for both the crisis centers and the other ones? Thanks.
Director Crosbie, you're recognized.
Thank you, Representative Reeder. Kelly Crosbie, Director of DMH DDS-US. So make sure I unpack all of the questions. On the crisis facilities, most of the crisis facilities are very much partnerships where we might supply some of the funding, the LMEMCO supplies some of the funding, and that could be with county dollars, state dollars, grant dollars, Medicaid dollars. They can't really build things with Medicaid dollars. They can pay for the services. And sometimes directly monies from the county. There are also entities that are bringing some of their own money to the table, like they raised money through foundations or they raised money from hospitals. So often those are large partnerships to be able to set up these facilities. One of the things that's important to us with this funding, though, I want to say it because it's incredibly important, is, we do ask because we want to know what the buy-in is from the community and from the facility, right? So we have this broad funding source for these facilities. But one of the things we want to make sure that doesn't happen is that the funding results in things like facilities refusing to take children from other counties, for example. So one of the things we're being very careful about is that even if a county adds money to a facility, if we're adding money to it, we've got to make sure that any child or any adult from any county in the facility is able to go. We need to have a statewide system. The regional thing just doesn't work. It needs to be a statewide system. The needs assessment for crisis facilities, yes. I don't know that we have the slide in the deck, Representative, but there is actually, besides looking at our own data for where we need crisis facilities to improve throughput in a region, there are also national models around beds per capita that you need for crisis. It is a national model, all states that use for predictive planning. We have used that data as well. And we've got information that we are happy to share with this committee about the predictive modeling there. On the child stuff, we are just getting started. So we know things like how many licensed beds we do have, where they are. It's interesting where they're clustered in the state. It's interesting how amount are in use versus staffed. We know how many children are in the facilities. We know their length of stay. We know their age. We know their diagnoses. But we do not have a good assessment of what the actual need is. That's really complicated. So I appreciate you asking the question. That is part of our work right now. We want to make sure that we have the right amount and the right kind of facilities, because I don't think we have that right now. We really don't. But we also want alternatives to facilities, because there are alternatives. Children can be served in their communities with wraparound supports rather than going to a facility. But that is part of this process, a thoughtful process. We just don't want to start a bunch of facilities. This is about meeting the needs of children. And we have to know what the needs are first and build sensibly and smartly.
Representative Cunningham.
Thank you, Mr. Chair. It was two items I want to bring up, and that is looking at community as a whole. Recently, it was an article that came out that 77% of young people cannot go in the military. It's three issues: obesity, mental illness, and drug use. And we're seeing that in our everyday society. And you all are doing an amazing job with all the moving parts. But one of the things that always come to mind is the incapacitated individual, because they still have rights. That is the hardest space to navigate, even as a parent or a legal guardian, to navigate that these individuals still have rights, and you can't make them take treatment. And that's one of the hardest things that keeps some of our places, spaces filled up. But looking at the individual for as establishing policy, most hospitals or most clinics that provide space, they do have standards of care in place. And it's usually based on the acuity of care that the client requires. If they need 15 minutes, if they need a whole 24 hours of whatever they need within that space. But we also know that sometimes the treating physician that is within the location may say this person needs level 4 care, which means psychiatric inpatient facility. And when they go to Medicaid, they sit before 5 or 6 people, and they determine whether they're going to provide that 4 level of care. How often are you seeing that happen? Because I know it happens. Is it because it's not a bed, or is it because the cost?
Director Crosbie.
Thanks, Representative Cunningham. And I want to make sure that I answer your question adequately. So if I don't, you'll let me know. Just to take it back a step, one of the things that we're looking at really is the process by which children are assessed, and it's determined what level of care that they need, and then the process they've got to go through to get that bed approved, and then having someone find a placement. Because that's not the most efficient of processes when a child is in crisis and needs treatment immediately. But I have to say that even at the end of it, what often happens is that everyone agrees a higher level of care is approved. It's not about cost. The higher level of care is approved, but we can't find a place for the child to go. So we know that there's a problem with having facilities who can meet the needs of our most complex children. But still, it can take too long for a child to get assessment, for that placement to get approved. And we want to make sure, and there are efforts that are ongoing with our partners at DSS, with our partners in the provider community and benchmarks, to make sure that we have well-trained assessors who do a really good job of making sure they're really assessing the needs of a child and recommending the best course of treatment. That's not to say our assessments are bad. It's really, since they drive so very much, we need to make sure they're swift and they're by well-trained folks so we get the best assessment. But I don't think we do see it's a clunky process, but I don't think we see anyone ever say, no, we're not doing that because of cost. I mean, that would be a real problem. But there is demand for things we don't have. There are services we don't have.
Thank you.
Follow up, Mr. Chair.
You could be brief, please.
Thank you. I have seen that happen, and that's why I said it. We've seen it happen even at the court level. So that's why I brought it up. Thank you.
Thank you. And if I'm sorry.
Go ahead, you're recognized.
Representative Cunningham, would love to hear more about those. That sort of, most of the kids in the public system that we talk about are funded by Medicaid. And so that, of course, in partnership with Medicaid, we'd want to know if there was any situation where a child with public funds was being denied because of funds. That would be good to know.
Thank you. Representative Blackwell, you're recognized for your 2-part with a 2-point cost up.
My unbounding respect for you causes me to limit myself.
Thank you. You're a kind person.
You started out your presentation, Director Crosbie, I think, talking about the need for infrastructure to provide for the behavioral health needs that we have. I understand that for purposes of the committee, it's good to give us a broad overview. But my question is this. We have several state psychiatric hospitals across the state. One of those is in my district, Broughton Hospital. We spent millions of dollars, and we took extra years to build the new hospital just to be sure it was right. And unless my information is outdated, we have multiple beds that are empty because we don't have staffing. We don't have a forensic unit there that I think was intended because of staffing issues. So it seems to me it's one thing to approach things generally as statewide, but it seems to me that we ought to worry about staffing the empty beds we've got, maybe even before we worry about creating more beds. Unless I'm mistaken, Mecklenburg County and Buncombe, which were on your list as being high areas of people in the ED, those are in the Broughton catchment area. So is there a specific plan to address that issue at that hospital and at the others? Or is it just part of an overall, we're going to throw money at stuff until we hopefully see a change?
Good question, Representative Blackwell. Director Crosbie, you're recognized.
Thank you, sir. And I actually, that's a fantastic question. And I know that Chief Deputy Secretary Benton is actually going to speak to some of that. So may I defer to him?
You may. Secretary Benton, you're recognized, sir.
Thank you, Mr. Chairman. Mark Benton, Department of Health and Human Services. Representative Blackwell, thank you for your comment and question. I could not agree more that we need to do many more things so that we can hire staff so that the current roughly 100 empty beds at Broughton Hospital are appropriately staffed so that we can admit individuals and hopefully get to a point that we no longer have a waiting list. Your point, I appreciate your point very much about a lot of what Director Crosbie talked about with investments in our behavioral health, urgent care, our facility-based crisis. The difference between funding staff and funding and providing some startup funds for these centers is the source of funding. I need recurring dollars to be able to hire staff, whereas Director Crosbie is leveraging much of the one-time money that this body was so incredibly generous to appropriate and is using that for sort of a one-time purpose. And as she noted, and as you will likely hear in our Medicaid presentation this afternoon, one of the other things that you did was put $220 million in recurring dollars so that we can increase the behavioral health rates. So Director Crosbie is going to help get the facilities opened, and we've got the behavioral health rates increased so that they have a line of revenue for that. Thank you, sir.
Thank you. We have 2 minutes, so just so the staff will know, you're never safe if you leave the staff. So I met Matt Gross about 10 years ago while he was on staff. The secretary and I agreed it wouldn't be good to share this. He was on a talk show, Senator Heiss, with Englishman and a guy from Texas, and they were down to the final question. You fill in the word and spell the word. And so he asked the Englishman who had $12,000, he was leading, said, fill in the word and be precise and spell the word. He said, Old MacDonald had a, and the Englishman said he had an estate, E-S-T-A-T-E, and the buzzer went off, and Mr. Gross was really getting excited now. He was getting animated, but the Texan was ahead of him with $11,000, and he said, fill in the word and think carefully about your answer. Old MacDonald had a, and the Texan said, he had a ranch, R-A-N-C-H. And by now, Mr. Gross was just, couldn't be contained. So he said, okay, Matt Gross, now think carefully. You're the only one left. Fill in the word and spell the word. He said, think carefully, because Matt was getting up close to his mic. He said, Old MacDonald had a, he said, he had a farm, E-I-E-I-O. Sorry, Matt. You can see me in my office after the meeting. This time we're going to discuss state facility staffing with Chief Deputy Secretary Mark Benton. You're recognized, sir.
Hey, thank you, Mr. Chairman, and I promise to keep this brief. As I start on these slides, I want to let the members of the committee know that on the row behind me, and would be the the young lady who is raising her hand is Robin Whalen. She is the CEO of our largest of our 3 state psychiatric hospitals. So she is responsible for running Central Regional Hospital in Butner. The other thing I'd like to share or remind is that it was back in February of 2023 when we provided, I think it was our last update on staffing, where we were with vacancies and turnover rates, and you'll see some references to where things have indeed improved, where perhaps some things haven't changed a whole lot, or maybe have gotten just a bit worse, but there is some hope on the horizon. A final reminder that under the Division of State-Operated Healthcare Facilities, we run 13 different facilities, 3 of which are psychiatric hospitals. We have 3 nursing homes that primarily serve individuals with neuromedical needs. We have 2 alcohol drug treatment centers. We have 3 facilities that serve individuals with developmental, with intellectual and developmental disabilities. We have a psychiatric residential treatment facility, and rounding out the 13 is that we have a weekday residential program called the Wright School in Durham that serves children school age with behavioral health issues. But what I thought I would do for the sake of this presentation and with Ms. Whalen's presence is to sort of focus in specifically on our 3 psychiatric hospitals, largely because the recruitment, retention challenges that we see in our 3 hospitals really are repeated over and over again in all of the facilities. So I think that even though while I'm focusing in on one setting of care, it really is very much applicable to all of our facilities. And the first slide I want to share with you is this one. And this is something I believe that you all know well, is that when you are running a state facility, it is a very different from your sort of run-of-the-mill Monday through Friday, 8 to 5 state agency. What Robin Whalen and her team and all of our other facility directors have the responsibility of doing is something quite different, which is ensuring that you have a wide array of staff to meet the needs of the patients that you are serving. They also have the added challenge of having to ensure that certain staff are there 3 shifts every day of the week, of every month, 365 days a year, whether it is inclement weather, whether it is snowing, whether we are facing a hurricane or other sort of elements. That is her responsibility. So what you'll see sort of surrounding this sort of fictitious patient are the kinds of skills and individuals that are needed to run a psychiatric hospital, certainly beginning with registered nurses at 12 o'clock, moving down through pharmacists and laboratorians and individuals that assist with taking x-rays, into social workers and psychologists, moving up to medical doctors and dentists, psychiatrists. The real the folks who provide the vast majority of the care and are the vast majority of the folks that we employ are the healthcare techs, the nurse aides in these facilities. You'll also note some of them have a little time clock beside their title. And that is because these particular areas have to have a presence 24 hours a day, 7 days a week. So, how are things in the facility? Well, and again, focusing just on our 3 psychiatric hospitals, Broughton, Central Regional in Butner, Cherry Hospital over in Goldsboro. We've shared with you the vacancy rate, not only the percentage, but the number of vacant staff, as well as the turnover rate. And the turnover rate is defined as individuals who come to work for the hospital but leave within 12 months. The good news on the turnover rate is that while you'll see the rates at 46%, 31%, 30%, as a whole, this is lower than the rate that we were seeing when we were before you on this topic back in February of 2023. The vacancy rate, again, you see it for each of the 3 hospitals. It was 30% on average across all 3 settings a year ago. So it has, perhaps at least for 2 hospitals, gotten a little worse, but it has certainly improved for Cherry Hospital. But even so, there are a lot of vacant positions in these facilities. And what that has required is that, again, Robin Whalen and her other fellow hospital CEOs have to rely heavily on professional temp agencies to fill in the gaps, particularly for those highly skilled individuals such as nurses and physicians, but also in trying to fill some of the critical certified nursing assistant positions. And as a whole, roughly half of our vacant positions right now are covered by temps. To Representative Blackwell's point, and I think this will illustrate this quite clearly, if you ask, okay, with that kind of vacancy rate, that kind of dependence on temps, what does that mean for your ability to serve or fill all of your beds in the respective hospitals? You'll see again here the 3 psychiatric hospitals listed. The first column is the sort of maximum number of beds that they could have open at any given time, and totaling about 894 beds across the 3 settings. But because we have such a high vacancy rate and reliance upon temps, we are not able to staff all of those beds. And then you'll see the sort of math from maximum number of beds that are staffed or open. And so what is the number of unstaffed beds? And it's roughly about 100 beds in each of the 3 hospitals. They come in just shy of 296. What is interesting to note is that right now, the most recent data we have on individuals, both adults and children, who are waiting for placement, so they have been screened as needing inpatient psychiatric care, totals 225. Now that is an improvement from a year ago when that number was actually a little north of 250. But if we had the ability to fully staff and open all of the unstaffed beds, that final column, we could eliminate the waiting list across the state. And the final point, and then I'm happy to open up for questions either for me or Ms. Whalen, is that certainly some of your recent initiatives, our initiatives, things that we have done collectively have been helping, but we are not there yet and not out of the woods. The legislative increases have certainly been appreciated. The sign-on bonuses and more recently the retention bonuses that you use some of the ARPA funds to give to the facilities to then pass on to staff, I think is probably one of the things that have certainly helped improved our turnover rate, and with it going down over the last year, and certainly the labor market adjustment reserves where we have been able to target the salaries of nurses, most recently the salaries of our healthcare techs and nurse aides who form the backbone of our hospitals. And so some of the early signs of success that I hope that you hear from me and you may hear from Ms. Whalen is that we actually are beginning to see increases in applicants. When I was chatting with Ms. Whalen as we were preparing for this presentation, she was sharing with me that, we are seeing more applicants, which is a good thing, but she still struggles with on average of losing 3 to 4 registered nurses every month, and only has the ability to sort of hire one back. And again, that applicant pool is not quite as robust as we want it to be. And again, just wanting to highlight the slight decline in our turnover rate, which is welcomed. So we are left with still challenges around competitive pay. We are not seeking nor asking that we match dollar for dollar for perhaps what Duke Hospital may pay one of their nurses or physicians and other staff, but we very much need to be in the ballpark. And where we are is in one of the outlying parking lots right now, just to use an analogy. And again, we rely heavily upon licensed staff through our private temp agencies. That is a benefit. It allows us to serve who we are currently serving, but it does come at an increased price. And of course, not surprising, staff who are picking up extra shifts and staying late are experiencing, understandably, burnout. And so with that, Mr. Chairman, that concludes my remarks. Happy to take any questions from you or the committee, and certainly, again, want to draw your attention to Ms. Whalen's presence here, who can share with you real time her role, her challenges running our largest state psychiatric hospital.
Thank you. Senator Bergen and Senator Heiss, you'll be next.
Thank you, Mr. Chairman. And if you've not been to Central Hospital, you need to go. I've been up there a couple of times, and Ms. Whalen, it's great to see you. Thank you for everything you do. It's a beautiful, clean facility that you feel like you're walking in, and it is a major hospital. So thank you. Ms. Whalen, can I direct a question to you, please, Mr. Chair? What three things, if you had the power to change, would you change so that you could staff and open all of your beds?
Robin Whalen, you're recognized.
Thank you. Wonderful to see you. Thank you for the amazing question, for the opportunity to be here. Our goal is to open all of our beds. That is what we're here for. That is why I joined, mental health, is to serve our state. And it breaks our hearts every day to have these beds closed and to see the waiting list that we have. But in order to provide safe, quality care, I have to have a robust staff to provide that safe care. And you saw the number of staff that have to be there 24/7. And so for us to be able to offer that care, I have to have the staffing present. And our agency staff are amazing. I'm grateful for them, but they're agency, they're temporary, they're not invested. So you can't go over a certain percentage of your staffing to be agency. You need it to be more permanent. So the three things that I would say that we desperately need is to raise our salaries for those staff members who are here 24/7. The labor market adjustment rates were wonderful for us this year. They just went into effect, and I've already seen for our healthcare technicians, we went from an average of maybe hiring 2 a month last year in 2023 to over 20 in the past 2 months. It's had that big of an effect. But for my registered nurses, it has been very difficult. Our salaries are ranging around $64,000, and for an agency, they can make over $110,000. And so not really a choice there for some folks when they're trying to make those decisions. And I'm in an area with a lot of amazing organizations and healthcare facilities who also make significantly more and have additional benefits. So we've looked at it and we've tried to raise our beginning salaries to $64,000, but I'm not getting anyone in there. And looking at comparisons, again, I'm not going to be a Duke, I'm not going to be at a UNC, but I'm thinking like if we got to 70,000, we could make a good starting salary and raise our midpoints. But that will take some funding for that. The second thing I would say is we need assistance with, our hiring practices to make them much smoother, less rules around it, so that I can hire someone truly on the spot and be able to offer them a competitive salary and a true, road in order to improve their career status throughout with the state. I remember when I started with the state, I was so proud. I still am every single day, and I want us to be a preferred employer. So I think we need a campaign around that and have an HR system that supports that to recruit people that want to make a difference in people's lives. And I'd say the third thing would be to truly have better partnerships with the community so that when I do bring in patients, there is a place for them to go once they're stabilized. A lot of the things that, Director Crosbie talked about are amazing. We need that next step down level of care because once the amazing folks I have at my hospital do a great job, we're a teaching facility, and once our patients become stabilized, it's often difficult to find those placements. And so by that, our beds are staying filled and unable to bring in new patients. So those would be three things, but I'd say the biggest one is I need the staff to come in first, so to be a preferred employer that pays competitive pay.
Senator Bergen, follow up.
Yes, sir. Thank you, Mr. Chairman. Could we look at, and I guess this is for you, Chief Deputy Benton, could we look just at Central and do an analysis of the total dollars that we're spending for all services that are outside, the different temps, the different agencies? I think we're spending the money. I just think we're spending it wrongly. And can we just take that one facility, do a deep dive, and I'll be happy to help on any of it, to dig into it, look at what we're spending, how we're spending it, and let's give her the tools to be able to do this. And if we fix one, maybe we can figure out how to fix the others too. So, Would that be possible, sir?
Mr. Chairman, Senator, Mark Benton, Health and Human Services, very happy to do that. And actually, it's stated that we should pull together for all three hospitals, and will.
Senator Heiss.
Thank you, Mr. Chairman. I'm trying to get my head around this concept, and it's, if we could get salaries up, those kind of things. But nursing shortage is bigger than the state's salary issue. If we put a huge increase and made them competitively with Duke and UNC tomorrow, probably no one would be surprised that Duke and UNC would respond that's coming in, and we would find ourselves with the same delta that exists, because that's the workforce. But if I brought in any of my local hospitals, any of my others, they would all tell you the exact same thing. Like, they cannot find a nursing workforce. I can show you hospitals that have wings that aren't functioning right now because they don't have staff to kind of operate them. And so it's got to be more than we could bring a salary up that's coming in. Other things I hear, and I guess to get you to respond to, at least historically, and maybe we've got it all fixed out right now, but the amount of time from when you post a position till someone starts work is inconsistent with a modern workforce. You go to any hospital, the one difference is you can start tomorrow. That's coming in. They may have to work you somewhere while your credentials get done, depending on what level you're providing. But we're going to have a couple panels to come interview you and whatever else, and wait for the position to close, and 12 other things that we're going to have to go through. And I struggle with this private staffing concept too. We are creating our own problems. When you are putting someone on the floor and paying them more for doing the job than your employees are doing, I understand the emergency situation you're in, but there's no way out till you cut it off. Because if you're a new nurse coming out, which path do you think you're going? You can go work for the staffing agency and make more for the same job than you can working for the facility, and have more control over your hours and your process of those kind of things. And then finally, I think, I'd ask questions like, is every facility we got fully staffed with clinical staffing for nursing programs? Do we have nursing students in every area so that our community colleges are putting out and our universities are putting out the maximum number of graduates that they can, and how are we opening that process up? But I think all that to say is that the solution to this can't just be we're going to get our salary competitive, because even from our point, the next time we can raise salary will be next year, and we'll see the private facilities do it in a week and respond. But I just wanted to see if they respond.
Representative Blackwell, I've been disappointed since this is in your district if you didn't have a question. Thank you, sir.
You're the last person I want to disappoint.
I know.
Probably I'm piggybacking off what Senator Heiss has just said. I remember the slide that I think Ms. Crosbie, but maybe it was Ms. Ford, put up, showing a graph of what was being paid to a staffer and somebody at Target. But as Senator Heiss, I think, has observed, we don't live in a static economic situation. We're always going to be chasing whoever is paying the greater rate. I was told not long ago by the folks at Broughton that they're losing people to the locally run UNC hospital in Morganton. And I remember reading in the newspaper, to go back to Senator Heiss's point about the shortage of just people generally, that the largest number of employees vacant in the county were at that hospital that's taking the nurses away from Broughton. And of course, the health department at home for the county says they're losing people to Broughton. So everybody's chasing after too few people, and it seems to me that rather than just this, that what we need from the department is some fresh thinking that combines what specifically do we need to do about these regulations that prevent you from hiring when the need is there and you've got a person standing there in front of you, and how do we deal with this salary issue that is ongoing? How do we use the dollars that we're paying temps now to maybe solve some of the salary needs? And I'm curious too, as we create more partnerships to deliver the services elsewhere, do we have some thought that they don't have the staffing problem, that they can solve it and we can't? Because otherwise we're just creating more infrastructure and still don't have the staff for them. That really wasn't a question. I apologize.
Okay, that was a statement, but it was a good one. Thank you. Representative Cunningham, you're recognized, ma'am.
Thank you, Mr. Chair. Secretary Benton, has the full implementation of the electronic records, is that completed?
Secretary Benton, you're recognized.
Thank you, Mr. Chairman. Representative Cunningham, we have begun the process of implementing the electronic health record. We've selected the vendor. It will be Epic. It will be across all of the settings. Our hope, if we stay on track, is to have the first modules up and running in all of the settings at the end of this calendar year.
Mr. Chair, just one last one.
Yes, ma'am.
Have we looked at transitional housing for stabilized clients that are leaving the state facilities?
Director Crosbie, you're recognized.
Kelly Crosbie, Director of the Division of Mental Health, Developmental, Disabilities, Substance Use Services. Thank you for that, Representative Cunningham. I can't tell you a solution right now, but with our crisis dollars and our justice dollars, we are looking at opportunities to support transitional housing. We know that's really important for getting people to step down out of state facilities, but also to step out of jail and prison. We just don't have enough. We're just trying to be thoughtful. We're looking at places that work, because I'm a mental health person, not a housing person. So I need to talk to experts in communities where it is working well, so we fund the right things. But yes, we are absolutely looking at that.
Thank you. If no other questions, Deputy Secretary Benton, you can take us to the bar and make sure we don't all get poisoned by the final modular.
Thank you, Mr. Chairman. This is our final presentation, and as you have teed it up very well, this is providing the committee with an update on bar inspections, and it's more specific to bars that serve certain food, like I think about eggs, seafood, meat and poultry that is either uncooked and then prepared and sold for the public. As I brought a subject matter expert for the previous presentation about our state facilities, I have a subject matter expert here with me who's sitting next to Ms. Whalen. And you may know him well. His name is Larry Michael. He's our state environmental health director. And so as I begin my remarks, just a couple of overarching points is that not all bars were impacted by the change in legislation in 2023, and that our overriding approach to helping folks come into compliance was certainly never to shut down a business or curtail their revenue, but it was really just to ensure that certain food that requires time and temperature control is appropriately handled and processed so the public doesn't get sick. And that finally, again, that we are not talking about sort of prepackaged food such as bags of pretzels or potato chips. We're not talking about garnishes, fruit garnishes for a drink. It really is specific to food that requires special handling. And so as a reminder, or sort of perhaps a little bit of context setting, that across North Carolina, there are 39,000, just to repeat, 39,000 food establishments that also handle certain food, again, thinking about eggs, seafood, raw meat, poultry that requires special handling. They all adhere to the National Food Code that is developed by the U.S. Department or the U.S. Food and Drug Administration, and this is the same food code that we use and is used in all other states. The next slide, which you probably have already read, sort of lays out some of the reasons why the food code is incredibly important. Again, it comes back to ensuring the health and safety of the public. And why is proper food handling, proper hygiene of restaurant or folks who are dealing with food, why is that important? That is because 1 out of 6 Americans every year get sick from contaminated food or beverages. And sadly, 3,000 individuals lose their lives every year because of a foodborne illness. Largely, these individuals are infants or an individual perhaps with a compromised immune system. The next slide just provided you just a bit of sort of the historical, sort of the statutes and regulations as when bars were subject to permitting by the local health department. There was a period of time they came out, but in 2023 they came back in. And to sort of provide a bit of context, not all bars are subject to the food permitting and inspection by the local health departments. A bar that only uses food or fruit as a garnish is exempt, as are bars that only that do not prepare or serve food for charging to the public. They too are excluded. A bar that may only make available for sale to the public prepackaged food and food that the customer opens. So it's been prepared and packaged and the customer opens it in the bar, those bars are excluded. And finally, bars that are designated as a private club. So again, it's a smaller number of bars that are, again, serving food that requires time and temperature control, again, thinking about meat, poultry, seafood. And again, they are being held to the same sort of food regulations, the same food code as small and pop restaurants and other 39,000 food establishments across the state. You may have heard from perhaps a constituent or two who is now having to come back into compliance or initially come into compliance. And where we have found is some of the basic requirements that are required by the National Food Code are fairly straightforward. And I think most folks would understand why they are needed, and one being like a sink for hand washing. You also, the food code requires that you have an area that is dedicated to storing food and food supplies. Also increasingly important to the food code is the ability to properly wash pots and pans, plates and utensils that again are being used by the public who is purchasing the food that is being prepared. And there are also requirements specific to certain equipment, but much of that depends upon the actual food or the menu and the food process being used. The latest data on bars that are having to come into compliance is that thus far we have 84 that have been fully permitted. Another 144 bars are currently in the review process, and we estimate sort of a combination of those two numbers, or perhaps even fewer, have not yet begun and still have a bit of work to do. Some of the concerns that we have heard, and again, given that there are 39,000 food establishments across the state that are permitted and subject to regular inspection, our local health departments have a lot of experience in this area and are ready and willing and able to reach out and provide consultation to any bars that find themselves in this category. But what we have heard from many is that they're concerned about the lack of time to actually make the required improvements. And as you may know, that we have extended the period of time to give them a bit more runway to come into compliance. Some are concerned around, do they have the adequate equipment? And again, we are providing assistance locally to help them with their food choices, which sometimes drive them to a particular piece of equipment or not. Some have expressed a lack of funding, and others have also talked about a lack of available space to actually continue serving the food that they are currently providing to the public for sale. Just to give you a quick rundown on this slide, these are the efforts that we have undertaken to assist those that have been impacted by the legislation and to educate them. And again, some of the efforts that we have done, and again, those that we have worked with. And that, Mr. Chairman, is just a very quick overview of our work in this particular area for the small number of bars, but happy to take any questions, and also, again, happy to defer a question, particularly one that may be more detail-oriented, to our state environmental health director.
Thank you for that. I'm sure most of us have received calls on that from our local elected officials. Are there any questions from my friends on the Senate side? Y'all haven't been to the bar lately to get anything like this? I know my friends on the House side don't go to any bars, particularly Representative Lou. Any other questions? Thank you, for each of you, for coming and for your presentation and for your enthusiasm and your knowledge and wisdom. We appreciate it. And with that, this meeting's adjourned.